Now we move to the next area, and it's my great pleasure to introduce Dr. Plamen Todorov. Dr. Plamen Todorov is working at the University of Plovdiv, a beautiful city in Bulgaria. And he's talking about the shoulder, maybe? Plamen, ready?
Yes, shoulder
Okay, thank you
and
very much.
shoulder and knee. Thank you. Now I'm trying to share my screen. So thank you, Esperanza, once again for introducing me. It's my great pleasure to be here with you today to talk about EFSUMB, development of EFSUMB recommendation for shoulder and knee. And my name is again Plamen Todorov, and I'm from the Plovdiv in Bulgaria. So the outline of this presentation will be separate for shoulder and knee, and it follow the clinical update about ultrasound in these joints. And because of lack of time, we're gonna concentrate on several of them, like for shoulder inflammatory conditions, rotator cuff pathologies, adhesive capsulitis. Then we're gonna uh, scroll quickly over the practical points and some limitations. And finally, we'll present you the recommendations about the shoulder. Then we'll have the same outline for the knee with the clinical update on the latest literature about inflammatory conditions in the knee, crystal arthropathies, osteoarthritis, injuries, many still, but we're gonna omit the other huge theme of knee trauma, and then we're gonna talk about the practical points, limitation, and recommendations. So we now start with the shoulder. For each of these clinical update, I'm gonna give you some examples from like images. So the posterior glenohumeral recess is the main site where effusion of synovitis in inflammatory diseases with or without power Dopplers should be sought. Power Doppler detection in the posterior glenohumeral recesses shown excellent reliability in the literature. So again, like an example, posterior glenohumeral recesses with some diffusion and synovitis inside between the scapula and the humerus. Also the same with power Doppler signal in the posterior recesses, and of course, don't, as Esperanza tell, don't forget that ultrasound is a dynamic examination, which gives a huge advantage of this method. Other things about the inflammatory conditions is the power Doppler can be detected inside the posterior recesses, like here in picture number 1, around the biceps tendon in picture 2, but usually not in the axillary recesses, like here in picture 3. Synovitis in the biceps tendon sheet appears after that of the posterior recesses and has low specificity for rheumatoid arthritis, but signal along the biceps tendon is quite specific for the rheumatoid arthritis to differentiate it from the rheumatoid from the osteoarthritis. When there's a effusion in the bicep tendon sheet without such effusion in the posterior recesses or in the axillary recesses, we talk about the tenosynovitis of the biceps tendon. Then we move to rotator cuff pathology, and there's consistent data that ultrasound and MRI has similar diagnostic accuracy in rotator cuff tears, and the poor sensitivity and specificity of ultrasound for detecting full thickness rotator cuff tears was reported to be over 90% in these tears. Ultrasound was shown also to have a low level inter-observer variability for the detection, classification, and localization of rotator cuff tears, like you see here in this picture. Full thickness rotator cuff tear, we can measure the retraction, so we can classify the size of the tendon, and also don't forget again that this is a dynamic maneuver. So in acute trauma, we can see actually the distort fibers. Ultrasound has also shown excellent reliability for assessing the fibrillar disruption, nevascularity, and the number and the length of calcification in rotator cuff tendinopathies like this calcification in the supraspinatus tendon. Also, this tendon thickness more than 6 millimeters, like here, or abnormal tendon extraction can be used with equal accuracy to MRI and to diagnose supraspinatus tendinopathy. In adhesive capsulitis, ultrasound may help identify several morphological and functional alterations at the level of the glenohumeral joint capsule, and especially the rotator interval that you see now in the picture, which is one of the sites that should be monitored in adhesive capsulitis. In addition, the inferior glenohumeral capsule thickness also was reported to be quite increased in adhesive capsulitis, and hypoechoic vascular soft tissue at rotator interval level can be found also in adhesive capsulitis, like here. In addition, ultrasound appears sensitive and specific imaging tool for identifying shoulder dislocation and reduction. So it has also application in acute shoulder trauma. Limitation of the normal rotator cuff tendon gliding could be also found in adhesive capsulitis, because this is dynamic maneuvers, and as you see here, the full range of motion of subscapularis tendon won't be seen in, so this is normal, won't be seen in adhesive capsulitis. Moving on to practical points, the glenohumeral joint effusion is best detected in posterior recesses with the arm in maximal external rotation or dynamically, while any other position can decrease actually the visualization by so much as 80%. So always perform dynamically maneuvers, as you see here now with external rotation. The effusion and the synovitis in the posterior recess is now visible, and you can see it with the ultrasound. The presence of more than 3 millimeter anechoic tissue around the bicepsal tendon, like in picture 1, superior to glenoid like in picture 2, or in the axillary recesses, like in picture 3, is the cutoff value for glenohumeral joint effusion. So we can measure here. In addition, the visualization of fluid in the biceps tendon sheath, like here, correlates significantly with the presence of rotator cuff tear, whether supraspinatus or subscapularis, like in this image. So when you see fluid in the biceps tendon sheath, always there's a need to evaluate also the rotator cuff tendons for pathology. Dynamic ultrasound might be helpful in detecting impingement syndromes, like here in the image with calcification that impinge on the acromion in abduction, and it cannot just slide beneath it. So there's impingement at the supraspinatus tendon. So dynamic maneuvers are very important, especially in the shoulder examination. For humeral ligament assessments, patients are scanned with the shoulder in neutral position, like here, while for the inferior aspect of the glenohumeral joint examination, this requires the shoulder to be positioned in maximal abduction and neutral rotation, like here. In shoulder instability, dynamic shoulder maneuvers such as external and internal rotation are high importance and should be performed with the patient sitting or in supine position in the settings of acute trauma of the shoulders. Of course, the ultrasound shoulder has some limitations, like the axillary recess is sensitive for fluid accumulation and detection, but it might be inaccessible due to the requirement for forced arm abduction, the image that I have shown on the previous slide. The diagnostic performance of ultrasound is lower in partial thickness tear, with sensitivity and specificity lower than for the full thickness tears. That also should be bear in mind. And also, ultrasound is inaccurate in evaluating tendon retraction for more than 30 millimeters and may underestimate the true tear size in this way. distal fibers of the coracohumeral ligament at the rotator interval may not be appropriately identified during static ultrasound examination, but again, we need a dynamic scanning here. And reliable inferior capsule measurement are hampered by the difficulty maintaining an abducted shoulder position. Again, this is a limitation for the examination in adhesive capsulitis, because the patient has a restricted range of motion. And based on this literature search and analysis of the data, we compose 4 recommendations about the shoulder. So ultrasound should be used to elucidate the origin of both inflammatory and non-inflammatory shoulder pathology, the level of evidence, because there's many data in the literature is one, strength of recommendation is strong, as was a broad consensus about this recommendation. Color Doppler ultrasound should be used to quantify the degree of inflammation in a rheumatic shoulder. Again, the level of evidence for this recommendation was 1, and the strength of recommendation were strong, agreed by a broad consensus by the experts. Ultrasound should be considered the first-line imaging modality in the rotator cuff pathology evaluation. The level of evidence, again, 1, and the strength of recommendation strong, and the consensus also of the authors was strong regarding this recommendation. And the last 4th recommendation about the shoulder said that ultrasound should be considered for identifying shoulder dislocation and reduction, with the level of evidence 1, strength of recommendation strong, and a broad consensus by the expert panel. So with this, we quickly move to knee. Again, outline is the same. The first clinical update is about the inflammatory conditions that affect the knee, and ultrasound has shown a greater sensitivity than clinical evaluation for detection of knee inflammation, like intra-articular effusion, synovial proliferation, and synovial inflammation activity. You see here on this longitudinal scan of the suprapatellar recessus, effusion, and some synovitis, also some Doppler signal, and the same on the third image. And again, the Doppler signal detection is best appreciated again dynamically. If we have material of tissue or fluid in the suprapatellar recessus, transducer pressure, a sonal palpation could be used to differentiate intra-articular fluid from synovial proliferation. Like here, we press with the transducer, and if the fluid will be pushed away, and we recognize that it is a fluid. Ultrasound is also more sensitive than clinical examination for detecting Baker cysts, including their rupture, like in this image on the right, and also with software panoramic, we can also evaluate huge Baker cysts protruding inside the calf. Then we're moving to crystal arthropathies. Ultrasound allows differentiation between CPD and urate crystal depositions according to the distribution of the pathological findings, with thick hyperechoic enhancement of the synovial surface of the cartilage, irrespective of the angle of insunation. Also called double contour sign, can be found in gout, like here and here, but in CPD, there is a hyperechoic foci within the articular cartilage substance, and the menisci, like this hyperechoic dots here in the medial meniscus, and also here inside the cartilage, we can see these dots. And if we magnify this image, then we can see the hyperechoic foci inside the cartilage layer. Considering the clinic update on the clinical application about the osteoarthritis, we have several domains like the cartilage, the new bone formation or osteophytes, the menisci protrusion, and the fluid. So ultrasound and MRI were found to be comparable, assessing the cartilage depth. effects. As you see here, the cartilage is well seen as a anechoic layer that is with equal thickness overlying the bone. Semi-quantitative grading and thickness measurements of the articular cartilage were sufficiently correlated with the MRI and also histology. And moreover, normative reference values can readily be established among population because this could be quite standardized to measure. In osteoarthritis, there is a progressive thinning of the cartilage layer that become more hyperechoic, more heterogeneous, thickened, and also the subchondral bone become uneven and not with a sharp contour like here. So this is about the cartilage. The other domain of osteoarthritis, osteophytes. Ultrasound gives superior sensitivity compared to conventional radiography for the detection of osteophytes. Grading scales for medial femoral osteophytes have also been developed with a very good agreement with the radiographic Algren Warren's grading system. And here you see osteophytes over the tibia and on the femur around the medial meniscus, big osteophytes here. So the osteophytes are readily visualized and assessed by the ultrasound. The next domain is the meniscal protrusion. The literature shows that the initial ultrasound finding of meniscal protrusion was found to be predictive for radiographic osteoarthritis. Both quantitative and semi-quantitative assessment of meniscal protrusion seems reliable when they were compared with MRI. So again, meniscal protrusion as a part of the knee osteoarthritis, also as you see here on this scan, and here on the other one is reliably can be assessed by ultrasound. And the fourth domain is the effusion for osteoarthritis. The presence of ultrasound detected effusion greater than 4 millimeters in the patellar recesses, so more than 4 millimeters here, and also in the video, predict subsequent worsening of the osteoarthritis of the knee. In addition, prompt detection, of course, of this fluid is contributory to an onward intervention in the knee, whether with injection or some other methods. Lastly, we'll briefly talk only about menisci, only this from the huge about the trauma of the knee. So ultrasound of the meniscus, especially medial, has a high negative predictive value of 93% and acceptable specificity for meniscal lesions. However, if damage to the meniscus with a possible requirement for operative procedure is suspected, MRI is necessary as the internal structure, internal part of the meniscus cannot be readily assessed. Otherwise, the outer part, as you see here, the meniscus is readily assessed, and we see here ruptures shown on these images, and left and right compression, again, a healthy meniscus and a ruptured one. So the negative predictive value is quite big for meniscal lesions. On practical points, a broad range of frequency linear probe could be used, and like for all joints, we need to assess in two perpendicular planes, like in the longitudinal plane and in the transverse plane, to image different structure and different diseases in the knee joint. The second clinical point said that the suprapatellar and lateral and medial, i.e. parapatellar recesses, should be scanned together to assess and to score interarticular information. So we need to scan the suprapatellar, but also the lateral and also the medial joint recesses for evaluation for synovitis or for hydrops, and not only the suprapatellar one. Knee position should be neutral, like in picture 1, or in 30-degree flexion to optimize sensitivity for effusion detection and for synovial proliferation detection, and maximal knee flexion, which facilitates detection of the crystal deposits in the cartilage and also the morphological features assessment of the hyaline cartilage. The recommendations for the knee that were developed after this literature search and analyze of the data were that ultrasound could be used to detect and characterize knee inflammatory abnormalities when the clinical assessment is insufficient or inconclusive. Level of evidence is 3. The strength of recommendation is weak for this recommendation. The consensus with which it was accepted was broad. In crystal-related arthritis of the knee, with or without symptoms like in CPD or gout, ultrasound is recommended for its high diagnostic accuracy. The level of evidence is 2, and the strength of recommendation is strong, and also the consensus by the authors was also strong for this recommendation. And ultrasound should be the third one. Ultrasound should be used to detect effusion, synovitis, cartilage damage, early bone proliferation, meniscal protrusion in the diagnosis and management of knee osteoarthritis, like all of the domain of osteoarthritis, the effusion, the cartilage damage, early bone proliferation, and the meniscal protrusion could be assessed by ultrasound in order to improve the diagnosis and management of knee osteoarthritis. The level of evidence were 2B, and strength of recommendation were strong for this recommendation. Also, the consensus was strong of the authors. With this, we are moving to the end of the presentation, and I want to thank Violeta Vlad, Michaela Miko, and for their work on the shoulder, Christian Tesch and Levent Oscar with the work on the knee, and a special thanks to Daniela Fodor and for Esperanza Nerado for their coordination and their work on this project, and for inviting me also. With this, I would like to thank you very much with some pictures from my hometown, and to wish you success with the webinar. Thank you very much.